Hey guys, it's Sarah here. In this video, I'm going to be going over a comprehensive nurse practitioner board review. So before I get started, if you want all these in note form, check out the link below. Otherwise, just follow along with me. Here's just a quick review of everything we're going to be going over. It basically covers your whole board. Okay, we're going to start off with dermatology. So here's just some terms you have to know. For instance, in the board, they'll say keloid. So you have to know what a keloid is. It's an overgrowth of the scar tissue. I'm not going to go through each one right now, but if you want, here's your list. Okay, so we're going to start off with benign skin lesions. So these are stuff that could be removed for cosmetic reasons, but otherwise you really don't have to do anything for them. So the first one I'm going to be talking about is a cherry angioma. In the boards and how it's usually described as a bright red or purple made of blood vessels. And for dermatology, it's really just about knowing the key differences that make one and another one. So for instance, for this, if you see a question that has those key words in it, you're going to think cherry angioma. And then if it says, like, what should you do for it? Like I just said, they're benign. You don't have to do anything for it unless the patient wants, cosmetic reasons or whatever. Okay, the next one is liver spots, which is solilongitinus. And that's going to be described as flat, oval, brown spots. So flat, oval, brown, just think of liver spots. The next one is sebaceous hyperplasia, and that's going to be yellow small bumps, usually around like the cheeks, the forehead, etc. Your next one is seborrheic keratosis, and that is usually warty, scaly, slightly raised. And the color is usually tan to black in color, and the key word is that they're going to say they're pasted on. So if you see something warty, pasted on, then just think of that. Your next one is just a skin tag. They're painless, just pretty much an outgrowth of the skin. So for all skin lesions in general, you want to do your A, B, C, D, E just to make sure they're not cancerous, and these are all benign. So just before I go on, I just want to say, in general, when we go through the cardiac system and the respiratory, we're going to be going into more detail in the pathophysiology. But over here, they're pretty much, for the board review, just about knowing the key differences. So let's go on to the next one. Okay, so candidiasis is a yeast infection. Usually people are at risk for it if they have antibiotic use, steroid use, basically anything that promotes yeast growth. Humid environment, obesity, if they have skin folds in there because it gets warm and they like to grow in that environment. It's usually described as a white cottage cheese discharge, and the treatment for that is obviously going to be to have good hygiene and antifungals, usually nystatin. So now I just made a chart between contact dermatitis and atopic dermatitis. Atopic dermatitis is known as eczema. Contact dermatitis is basically when you have something and you have a skin irritation or reaction from that. Let's just say a bracelet, and then around that you'll see it. So that's going to be your key. It's going to clue you in because it's going to be the shape of whatever it is. Let's say you have a bracelet. It's going to be the shape of that. Or it's going to follow the certain pattern that whatever you have a reaction to. With eczema, it's not going to be like that at all. It's usually found in the face, the neck, the knees, the elbows, antecubital. And the key thing for that is crusty yellow. It's going to say like crusty yellow because it starts out at red, little vesicles, and then it goes into crusty yellow. What you should know about that is for that you're going to be giving, emollients, topical steroids like hydrocortisone. If it's itching, because it could be itching, you give them antihistamines and, basically tell them don't scratch it, don't touch it, etc. Next we go on to folliculitis, which is an infection of the hair follicles. If it keeps spreading, then it's known as pharynx, and when it's a cluster of them, it's known as carbuncle. So we see over here, I showed the picture so you can see the difference between folliculitis, pharynx, and carbuncle. If it's just folliculitis, you just tell them to change out their razors, warm compress, etc. If it's a pharynx, then if the abscess is big, then you might need an IND. Otherwise, you could just do a warm compress, etc. For carbuncle, you always want to get a culture and sensitivity and medication. Next, we go on to hand, foot, and mouth disease, which is caused by Kawasaki virus. It's very common in kids, especially if they go to daycare, and highly contagious. Your symptoms are going to be fever, rash, but the key features is that it's going to be in the hand, foot, and mouth. So as the name says over there. Treatment is honestly just supportive treatment. Next we go into impetigo. Impetigo is basically a superficial bacteria infection of the skin. So think about it, kid gets a cut, bacteria gets in, and it's pretty simple. It's very common in kids, and the key feature of how it's going to be described is honey-colored scab. Just honey color. Anytime you see honey color, just think impetigo. The treatment for that is going to be a topical antibiotic ointment like mupirocin, but if it's all over, then it could be an oral one like Keflex. You want them to return to school after 48 to 72 hours after starting treatment. Your next one we're going to be discussing is pityriasis rosea. Excuse my pronunciation for any of these diseases. That key feature is going to be a Harrell patch. And what I mean by that is, if you look at the picture over here, it's a huge oval round patch and then small ones around it. So it's going to start out with the oval patch, big one, it's called a Harrell patch, and then after that you're going to get little ones around it. There's really nothing to do about it, but it's a lot of times tested on the exam just because of the key feature. And next we're going to go on to psoriasis. Psoriasis is very common. And when I say very common, that's quite important because anything that's common will generally be tested on. Anyways, it's a chronic inflammatory skin disorder, and there's a lot of different types, but they're not going to test you on which type it is. All you have to know is the symptom. It's going to be described as a silvery, scaly. Anytime you see scaly, it's usually psoriasis. It's really common on the elbows, as you see in the picture, knees, scalp. The treatment for that is pretty much long-term because it's kind of chronic. There's numerous topical systemic therapies that are good based on all different things. Usually like a topical corticosteroid. Next we're going to go on to scabies. So scabies, as we all know, is from the scabies mite. The key feature to that is itching. Almost always are they itching, small little red bumps. And another key feature is that it's going to be an interdigital. So you see finger like in between the web, I guess you would say. So they like to ask that also. Treatment for that is permethrin cream. The next one is vitiligo. Vitiligo is hypopigmentation, so you see the white spots because it's hypopigmentation. Usually associated with autoimmune disorders, but you just want to know that it does affect their body image a lot. So you could refer them to dermatology for treatment to help with that. Next we're going to go on to lipoma. Lipoma is a benign tumor made of fat cells. It's very slow, asymptomatic, and you really don't have to do anything about it. Only if it gets really large and irritating. But you're going to feel them, it's like under the skin, you're going to feel a round, rubbery, movable thing under the skin, and there's really nothing to do about it. The next one is acanthosis nigricans, which is basically, it's hyperpigmentation of the skin, a little velvety or brownish. It's usually associated with endocrine or metabolic disorders. Like it's usually disordered with like insulin resistant, obesity, etc. Over here, I made like a little chart between acne rosacea and acne vulgaris. Acne vulgaris is like your regular acne that you know of, on your skin and stuff like that. Acne rosacea is a little bit different. It's a flushing and dilation of the blood vessels. The treatment for that is going to be avoid the sunlight, wash your face, medications if needed. And for acne, you first want to start off just with proper cleansing, mild soaps, decrease their stress. If it's mild, you could give them a topical benzoyl peroxide. If it's moderate, you give them topical and oral antibiotics like tetracycline. If it's really severe, you want to refer them to dermatology to prescribe something like isotretinoin and something like that. Okay, now we're going to compare and contrast cellulitis and erysipelas. So cellulitis, as we've seen in the picture below, it's an infection of the lower dermis and subcutaneous tissues. Erysipelas is a superficial form of cellulitis, but affects the upper dermis and extends to the superficial cutaneous lymphatics. They're going to be treated the same way, antibiotics, but the key difference is with cellulitis, the lesions are going to be generalized and there's no well-defined margins. And with erysipelas, the lesions are going to be localized and have a clear, demarcated boundaries and non-purulent. So if you see in the question, it says clear, demarcated boundaries, you want to think erysipelas. And if you see in the question, it says like pus, pustular, then you could think more like cellulitis. Next, we're going to go on to necrotizing fasciitis, and that's actually an infection of the deep soft tissue. It could lead to destruction, so you want to send to the ER right away. It's usually caused by bacteria entering the opening of the skin, and the symptoms are going to be red or like purplish, edema. It's going to rapidly increase in size. It's going to be painful. They're going to have systemic symptoms, etc. Next one, we go on to varicella zoster, which is red blood chicken pox. We all know how that looks, but the key how they differentiate it is by different stages of healing. Something else is also going to say different stages of healing is going to be when you're talking about abuse. Bruising all over the body could be different stages of healing. But if it's going this way and the question asks more like, fever and stuff like that, then you want to think of chicken pox. It usually starts out on the head and it spreads to the rest of the body. It's contagious until all the lesions usually crust over, usually about 2 weeks. It stays in the body, and when it's reactivated, it's called shingles, herpes zoster. So now herpes zoster is, the key feature to that is going to be that it's going to be in a dermatome pattern. It usually is very painful. That's another key thing, and it's usually between 50 and up. You usually get it. Treatment for that is going to be a cyclovir, and you want to start as soon as possible. Next, we go on to paronychia, and that is an inflammation of the skin around the finger, usually like right over here. Usually from bacteria, usually from a manicure, very common, especially because the stuff are not really clean that much. Symptoms are really going to be red and swelling around the nail, and it could turn into an abscess. Treatment for that, if there's an abscess, you always want to do I&D. Otherwise, soak it in water and topical antibiotics like mupirocin. Next, we're going to go on to anaphylaxis. As we all know what that is, it's a hypersensitivity reaction caused from a lot of different stuff, medication, food, etc. Symptoms, like get hives, angioedema, shortness of breath, wheezing. What you want to give them is, you want to give them epi 0.3 to 0.5 IM mid outer thigh. You want to repeat that every 5 to 15 minutes as needed, and obviously call 911. Rocky Mountain Spotty Fever. That is a tick-related disease. Symptoms are going to be flu-like symptoms in the spring, summertime. There's also going to be a rash, like petechia rash, that comes day 4 or 5 after the symptoms begin. And there's a really high mortality for this, so this has to be treated right away. If you suspect this, you treat before the labs come back. Treatment, doxycycline. Whenever we talk about Lyme, doxycycline. We're going to go on to erythema migrans. That is also talking about Lyme disease, but it's a rash that comes in the early stages of Lyme disease. Come any time between day 1 to a month after tick bite. But the key feature to this is going to look like a target lesion, like target symbol. So it's going to look like a bull's eye rash with central, like, or ring-like clearance. So that's going to be your key thing. Bull's eye rash, target lesion, central like clearance. Treatment, like we said, for Lyme, doxycycline. The next one we should know about is meningothema. That is actually very rare, but very fatal. So that's why we have to know about it. Besides for the sudden onset of high fever, meningitis symptoms, also going to have a hemorrhagic rash that does not become pale when you put pressure on it. If you suspect this, immediate to the ED. Send them to the ED. The next one is herpes zoster ophthalmicus, and that's a reactivation of the shingles virus in the ophthalmic branch of the trigeminal nerve. The key thing that you're going to see over here that's going to stick out is a vesicular rash on the tip of their nose. So it's going to be on the forehead, scalp, and the tip of their nose. You want to refer them right away out. Okay, next we go on, so melanoma we just skipped because we all basically know that, the A, B, C, D, E's of melanoma. Next one is a different type of cancer, but it has a low metastatic potential, unlike melanoma, which is very deadly. So your basal cell carcinoma is your low metastatic potential. It's usually caused from sun exposure, light skin, but your symptoms that's going to stick out is going to say pearly. So pearly white and waxy with an ulcerative center. So pearly if you see that, waxy if you see that, and ulcerative center. And obviously it doesn't heal because it's skin cancer. The next one is subuncal hematoma, which is a collection of blood just under the finger or toenail even, and it has to be drained because then the blood's going to build up nowhere to go. The next one that we're going to be talking about is actinic keratosis, And this over here is scaly, rough patch from chronic sun exposure. So if you actually understand what's going on, then you'll be able to answer the question. Because in the question, it will say, like, 60-year-old man likes to, has a history of being outside. Then you'll be like, oh, sun exposure, and then think, actinic keratosis. So this could become more like a squamous cell carcinoma. So this you want to refer right away out. Next, we're going to be going on to fungal skin infections. So tinea is a fungal skin infection. They're all different types. It could be capitis on the head, it could be pedis on the feet, all different types. Treatment is going to be topical antifungal, like your azoles, but if it's on the head, you want to give oral. Next, we go on to tinea vesicolor, and that's going to be a hypopigmentation, round macules on the trunk. Treatment for that is also going to be your topical antifungals, like ketanazole, etc. Okay, next we go on to bites. So you have your animal bites, your human bites. With animal bites, dog bites are very common, but cat bites are actually pretty infectious. You always want to get a good H&P. Does the animal have rabies, immunization, etc. With the human bites, you want to watch out for closed fist injury. So like when they clench your fist, it hits the teeth. Because they're pretty high risk for infection. Treatment for both, obviously you want to control the bleeding, you want to wash it right away. Don't suture it if it's high risk for infection, like a cat bite, or if it's a deep wound, puncture wound, wounds that are more than a certain amount of hours old, etc. If it's infected, you give antibiotics, it's usually augmentin, and give a tetanus shot if they didn't have one within 10 years. If it's not infected, 5 years. Next we go on to burns. You have your first degree, your second degree, and your third degree. So third degree is going to be a full thickness burn. That's always burn center. We don't take care of that. The first degree you're going to have, it's just going to be red and painful. What you want to do, you want to put them under water, give them soap, cold pack. If the skin is not intact, topical antibiotics, aloe vera. For your second degree, you have your partial thickness, so they might have some blistering. It could be very painful also. You give them silver sulfidine cream, dressing, etc. On top is just really your rule of nines, but it's just plain memorization. There's nothing for me to go over. We go on to our wounds. This is just a little, pathophysiology about wounds. Okay, next we go on to eyes now. Eyes, here's just, what a normal eye should look like, terms you should know. So like I said, if they say the patient has meiosis, you have to know what meiosis is. So these are just terms you should know, what a normal eye should look like, and that's pretty much it. There are abnormal eye findings, so if you're in primary care and you're finding this, you always want to refer these patients out. So hypertension and diabetes could affect the eyes. You're going to have your hypertensive retinopathy, and you're going to have your diabetes retinopathy. On exam, for someone with hypertension, you could find all this stuff over here. They have the flame-shaped hemorrhages. You have cotton wool spots. You basically have to memorize this. And for your diabetes, you're going to see cotton wool spots, microaneurysms, heart exudate, neovascularization, all those different stuff. It's just plain memorization of what you could find, etc. So now we go into eye disease. Corneal ulcer. Corneal ulcer is basically an open sore of the cornea caused by infection. It's very common with contact lens users. When we talk about the eye, contact lens users are at an increase for a lot of different stuff, just because if you think about it, they keep going like that in and out of their eye, so bacteria is on their hand, they put it into their eye, especially a lot of people don't wash their hands before, and then you're introducing it right into their eye. So anyways, for this, you're going to see white lesions on the cornea, and you want to refer them to the ED because this could actually lead to scarring or perforation. The next thing you want to refer out also to is herpes keratitis. Herpes keratitis is a viral, because as the name says, herpes, eye infection caused by HSV. They're gonna come with eye pain, photophobia, blurry vision. Refer them out. The next one we're going to talk about is glaucoma. So glaucoma, you're going to have your open angle and your acute angle closure. And there's a big difference because what's happening is that there's an increase in the pressure in the eye that's affecting the optic nerve. But with open angle, it's going to be gradual. So it's going to be gradually built up. And the reason And the way you're going to know that is by the symptoms. They're going to start having peripheral vision loss slowly, come to central vision loss very slowly. With your acute angle closure, it's just all of a sudden, complete blockage, and the pressure is going to rise up really fast and blindness could occur. So these ones you want to send out right away. So next we go on to retinal detachment. So retinal detachment is exactly how the name says. The retina is being detached, like pulled away from its normal position. This is an immediate referral to the ED also. This has very specific symptoms that are going to be described. Number one, it's going to be described like a shade or curtain in the vision, or floaters, flashing lights. If you hear any of those, just think of retinal detachment. Next one is optic neuritis. That is, itis is inflammation, so inflammation of the optic nerve. That's a lot of times associated with MS, so it'll be like the first symptom of MS. And symptoms for that's going to be described is going to be like a donut in their vision or a blind spot in their vision, and that you want to refer them out also. Now here are conditions that we don't need to send to the ED that are not immediate emergencies. Number one is blepharitis. So that is itis, inflammation of the eyelid, like where the eyelashes are part of it. It's usually from clogs, from oil. Symptoms are swollen, red, itchy lids. They could have like a little scaly dandruff on their eyelashes. And treatment for that is going to be like a baby shampoo, Baby Johnson shampoo, warm water. You could give them topical antibiotic solution like the eye drops, and warm compresses. And obviously teach them about good lid hygiene, eliminate triggers like allergens, etc. The next one, you have your presbyopia, which is gradual loss of farsightedness. This usually starts around the age of 40, and what you should know about this is that it's a normal part of aging. The next one is cataracts. Cataracts are painless. That's a key one. And symptoms are going to be like difficulty during night, driving, blurred vision, etc. The next one is going to be a corneal abrasion, which is basically a scratch on the cornea. It could be from the hair, from a fingernail, from a tree branch, anything like that. The key thing over here is they're going to say they have a foreign bodied sensation, like they're going to feel like something's in their eye. You always want to rule out obviously a penetrating trauma first, and you can flush it to normal saline to remove the foreign object. If you cannot refer it out, you want to refer them out and give them antibiotic ointment. Okay, next we're going to go into iritis, which is inflammation of the inner eyelid. So I just like think of inner eye, like the blood vessels, etc. They're going to be very sensitive to light, have a headache over their eye, and their whole eye is going to be red. You want to refer them out to ophthalmology. Next one is a subconjunctival hemorrhage. So that's when you have a blood vessel, it just breaks. So it could be from local trauma, from lifting, straining, etc., coughing even. But what you should know about this is that it resolves on its own. It may look bad, but it resolves on its own, usually in around 1 to 3 weeks. And just follow up to make sure it resolves. The next one is arcus annulus, which that's going to be described as a light gray or white ring around the cornea. This is caused from cholesterol, so you want to do a lipid panel for them, and it's honestly normal as they age. The next one is exanthalmusa, however you pronounce that, and that's cholesterol yellow deposits around the eye. It causes from high cholesterol, so that also you want to run a lipid panel. Here we're going to compare and contrast bacterial, viral, and allergic conjunctivitis. So first of all, you can see the difference, and what sticks out, number one, is on the left side, you see the yellow, gooky, mucopurulent, crusty one. So that's always going to be bacterial, and that you're going to give antibiotics for. For your viral and allergic, your key distinguishing features, because they're both going to be watery, etc., is that one's going to be itchy. So itchy is going to be the allergic, just watery is going to be viral. Okay, and then over here you could compare and contrast these two. So if you actually look at the picture, the surfer's eye, you see how it extends on the white part see the white part extends into the color part of the eye, so that's going to be your key differentiating. They're both caused by chronic sun exposure, and you can refer them to ophthalmology, tell them to wear good sunglasses. Okay, next we go on to the ears. So over here, a quick pathophysiology and what a normal ear is supposed to look at. The things that you're going to have to know for here, for your test, is the Weber's and the Rene's test. The Weber is that when you take a tuning fork, you put it on the forehead, ask them if they could hear on both sides and which side they hear more. So there should be no lateralization. And by no lateralization means that they should be able to hear them both equally on both sides. For the Rene's test, it's the same thing, but meaning that you're taking the tuning fork, we can put it on the mastoid process. When they can hear it, then you're going to put it on the front of their ear. It should be that the ear conduction is longer than the bone conduction. If it's the opposite, that the bone is longer than the ear conduction, then it's conductive hearing loss. If it's equal, then it's sensory nerve hearing loss. So here are some ear diseases that you should know about. So first one, cholesteatoma is abnormal skin cysts in the middle of the ear. The thing that's going to stick out for this is that it's going to be described as a cauliflower-like mass. So anytime you see like a cauliflower-like mass, you want to think of that. Treatment is usually going to be surgery. You want to refer them out because we can't deal with this in primary care. The next one is a basal skull fracture. The key symptom for that is going to be the raccoon eyes and the battle sign. The raccoon eyes, exactly how the name sounds, all around the eye, and the battle sign is going to be bruising behind the ear. So if someone falls or is in a trauma and you have any of those signs, then immediately refer them to the ED. The next one is going to be acute otitis media, which is an ear infection, as we all know. They're going to come in with regular ear pain, decreased hearing, muffled hearing, popping sounds, and they're going to be put on antibiotics. So next we go on to the nose. When we talk about the nose, you have allergic rhinitis, which is inflammation of the nose caused by allergens. They're going to have irregular symptoms and nasal congestion, itchy, sneezing, coughing. The reason why coughing is because they'll have the postnasal drip, so they'll be laying down and then they'll start coughing. For that, you want to give topical nasal sprays like fluticasone, and if that doesn't work, go on to your topical antihistamine nasal sprays, etc. For nosebleed, which is epistaxis, you want to apply direct pressure. You could give your Afrin if needed. You could tell them that they could also put petroleum jelly or Vaseline to their nares so that it doesn't dry out. If it's recurrent, you could refer them to the ENT, and if it's posterior nosebleed, ED, emergency department. So next we go on to the mouth and throat. So these are just regular information about the mouth and throat, and we're going to be talking about Navol's tooth. So that's when a complete tooth comes out of its socket. That's considered a dental emergency. If it's a primary tooth, then you don't have to reimplant it because the kid's tooth will, the other tooth will grow in. But if it's a permanent tooth, then you want to save it. You want to put it in normal saline, and you want to rinse the tooth, irrigate the socket, and reimplant the tooth. You want to have them bite down on a gauze and immediately refer them to the dentist. If you can't reimplant it back in, then you want to store the tooth in cold milk, normal saline, etc. So next we go on to leukoplakia. So leukoplakia is a white gray patch in the mouth. What you want to know about this is that cannot be brushed off. So you always want to rule out oral cancer. So send them out for, they're going to have a biopsy. If it's really cancer, surgery, stop the risk factors, etc. The next one is a canker sore. Usually heals within 7 to 10 days. Treatment could be magic mouthwash, over-the-counter stuff, etc. You have your geographic tongue. So geographic tongue is just as the name sounds. You're going to have a tongue. If you actually look at it, it's going to be like patches. It's kind of like a map, which is why it's called that. It's benign. A lot of times they're born with it, but you should know that it can have an increased sensitivity to spices, salts, etc. Sometimes it could even actually get like more prominent before they have a virus. It could be like their sign that they're getting sick. The next one we're going to go on to is peritonsillar abscess. That is an abscess that forms in the throat next to the tonsils. Symptoms, they're going to have the key one that going to differentiate on the boards, it's going to be a muffled, hot potato voice. You want to refer this patient immediately to the ED. Okay, next we go into strep. So we all know what strep is, but you should know for that you have a center criteria. And this helps us to know if we should swab people, helps us to know if we're going to think of strep. So for that, you're going to have your tonsillar exudate, tender anterior cervical adenopathy, fever, absent cough. In general, if it's 0 to 1, no testing, no treat. If it's 2 to 3, you could do a rapid stress test. 4, treat empirically. For the treatment, you're going to give them amoxicillin. Normally, if they're allergic, give them azithromycin, which is Z-Pak. Untreated strep could lead to rheumatic fever, glomerulonephritis, so you do want to treat it. The next one we're going to be talking about is mono. Mono is caused by the Epstein-Barr virus. Key features is going to be fatigue. They're going to have the other features also, even a sore throat, but the key feature is going to be fatigue. For that, what you want to watch out for is the spleen. So you want to tell them no doing sports, especially if their spleen's enlarged, and if their spleen isn't large, you want to repeat an ultrasound after a few weeks, etc. And over here, it's just information about lymph nodes and sinuses, just like a little patho. Okay, so for your nervous system, there are multiple tests a lot of different things. I'm just going to be going over very non-specific. So your cerebellum, if you want to test that, you could test a gait, you could do a tandem walk, which is basically 1 foot in front of the neck. You could do your rapid alternating movement, which is basically taking your hands and going like that on your knees. And you could do your heel to shin. So this is your foot, your other foot's just going down it, down. You could do your proprioception in order to test for that, do sensory information. You could test them with the Romberg test, which is basically you're going to put your feet together, your hands are going to be straight out, and you're going to close your eyes. If they sway, then it's positive, or if they fall. You also could test your motor test. You could test that with your range of motion, ask them to move everything, flexion, extension, the pronator drift test, which is they're going to hold their hands with the palm facing up, eyes closed, so like this, eyes closed. If their hands fall down, then positive. Your dermatomes, I wouldn't really get into that. They don't really test on that. And then here's just terminology that you should know because it could be in the question and they're not going to explain what it is. So you do have to know your cranial nerves. And this is basically a mnemonics that I like to use. So for 1, you have 1 nose, so think of nose. You have 2 eyes, so cranial nerve 2 is eyes. 3, 4, 6, your eyes do tricks, so 3 and 4 and 6 are all eyes. 5, it rhymes with tri, so I think of the trigeminal nerve. 7, it fits perfectly in a face, so I think of 7. 8 is like a twisted ear, so that's why I think of the ear. 9, so 9 is your glossopharyngeal. That was a little harder to come up with a mnemonic, and how I just like to remember it is that 9 looks like a G upside down, and also it's the glossopharyngeal, so that's for gag reflex, and that's pretty much it. 10 is the vagus, so I think of Las Vegas, like you would give Las Vegas a 10 out of 10, and so vagus nerve. Your 11, your spinal accessories, just think of a 1 and a 1, like in the picture like that. Like you could place them on each of your shoulder. And 12 is your hypoglossal. I think of your teenager, chewing gum, speaking disrespectfully, etc. And now we're going to go into headaches. There are 4 different types of headaches. So when someone comes in with a headache, there are some really dangerous stuff it could be that you always want to rule out, like aneurysm, meningitis, increased ICP, brain tumors, arachnoid hemorrhages, etc. So usually those would come with a neurodeficit or change in LOC, but you always want to, be sure it's not that. But these are just your regular headaches. So if someone has a cluster headache, the key differentiating one for that is going to be a sharp tearing and nasal congestion. For that, that's the only one that you're going to give high flow oxygen. So just think of cluster, like a lot of oxygen in a tank, and high flow oxygen. Migraine, the key differentiating thing for that is a lot of times they have an aura and it's photosensitivity. So if you see something with headache with photosensitivity aura, just think of migraine. Tension, how they're going to describe it, it's usually like a band-like or a squeezing. and it's usually from stress. You'll see like someone works so many hours, or a stressed out person, usually tension. Medication overuse is pretty simple because it's just from medication, and you're just gonna DC the medication. In general, for a lot of these headaches, prophylactic, you can give a TCA, tricyclic antidepressant, a beta blocker, and during the attack, you want to give like an NSAID, except for the cluster, which is high flow. You could also give them a triptan, like a sumatriptan, which is a migraine medication. Next, we go on to giant cell arteritis, which is also called temporal arteritis. So that is a large vessel vasculitis that causes a headache. Vision loss, scalp, the jaw is going to hurt. It almost never occurs before 50. So someone after 50 comes in with a headache, you want to put this on your differential. If an 18-year-old, you might not be the first thing on your differential. Because it's a vasculitis, the labs are going to be elevated with the inflammation, so the CRP, ESR are going to be elevated. The only really true way to diagnose is a temporal artery biopsy, and they're going to be treated with steroids for several weeks. Next, we go on to Bell palsy. So Bell palsy is your cranial nerve 7 dysfunction, as opposed to trigeminal neuralgia is your cranial nerve 5 dysfunction. Bell palsy a lot of times comes in with symptoms of a stroke because they're going to have a unilateral facial paralysis. So you obviously always want to rule that out, but the treatment is going to be your prednisone for a week. Now we talk about strokes. Strokes, you have your ischemic and hemorrhagic. Ischemic is basically a blocked artery, hemorrhagic is bleeding in the brain. They're going to come in a lot of times with the same symptoms, but the one key differentiating one is going to be the worst headache of my life. The worst headache of my life is usually the hemorrhagic one. We all know like what the symptoms are for stroke, so I'm going to skip that. TIA, as we all know, is a mini stroke. It usually lasts under 24 hours. And this is key because you have to identify there are risks for having another stroke. So you want to reduce the risk factors, treat their hypertension, high cholesterol, lifestyle modifications, etc. Next, we go into Parkinson's. So Parkinson's is mainly going to be under the neurologist for treatment, but if you do see someone who could have Parkinson's, you do want to work them up. The key one for that is going to be the tremors, rigidity, but the tremors are going to be resting tremors. So resting tremors means that even at rest, as opposed to essential tremors are when you like reach out for an item and then they start shaking, but resting tremors, just at rest, they're shaking. They're usually going to be treated with medication because unfortunately there's no cure for it, so it's going to be like levodopa, carbidopa, etc. But this is going to be handled by neurologists. Multiple sclerosis comes in, it's a little hard to diagnose because it's so many different symptoms that you could be like, oh, it's something else. Like vision, balance issues, muscle weakness. Even when they are diagnosed, they could be good for like years and then they go into a lot of remission, exacerbations, but they could be good for years and then go in like just on and on. This is going to be referred to neurologists also. It's usually between the age of 30 to 50 where they are diagnosed. Here are some meningitis signs that you could test for. As we all know, meningitis comes in with irregular symptoms, with the headache, the nuchal rigidity, etc. But these are two signs you could do. The Practitioner sign is when, as you see in the picture, you're going to place their knee at a 90 degree and slowly extend. If it's painful for them, that's positive for meningitis. The Brudzinski sign is that when you're going to flex their head like that, their feet are automatically going to be flexed with it. Next, we go on to Alzheimer's disease. Unfortunately, there's no cure for that. It's really just to slow the progression with medications. That's going to be prescribed by neurologists also, not you, but what we should know as primary care is you want to be careful for their safety. So are they able to drive? Are they at risk for getting lost, etc. Next, we go into seizures. So I'm just going to be talking about two different types, your absent seizures and your tonic-clonic. Absent seizures are very common in kids. They kind of just like stare into space and then all of a sudden they get back in. So a lot of times you don't even like realize it's a seizure. It's kind of just like a brief loss of consciousness or brief like stare into space and then they're just like back in. So that's diagnosed through EEG and it's usually honestly outgrown. Your tonic-clonic is, your tonic is going to be straight, clonic is going to be the jerkiness that you're going to see, that you want to put them on their side for, you're afraid that they're going to aspirate, and you want to handle that by neurology. There's a few different reasons someone could have vertigo: Meniere's disease, PBV, labyrinthitis, cerebral infarcts. Someone has benign paroxysmal positional vertigo. That's very common. They're going to think like they're having like a stroke or something. They're going to have sudden vertigo. Anytime they move their head anyway, it's going to go back into like a whole thing again. And the treatment for that is methylazine. A test you could do the Dix-Haplix maneuver, but the treatment is going to be methylazine. If someone does have vertigo, but it comes with like limb weakness or slurred speech, then you want to think of cerebral infarct and send them to the ED. Next, we go on to carpal tunnel. So carpal tunnel, unfortunately, very common because it's caused by a lot of wrists and hands, like if they're typing a lot, and a lot of people are on the computer, or if they swing bats and stuff like that, if they're moving their hand and keep typing, keep opening bottles, stuff like that. So here are two tests that you could do to test. The Tinel sign is going to be, you have the median nerve, you're going to tap on it, and if they feel numbness or tingling, then it's positive. The other one is the Fallon sign, and I just think of P because prayer and Fallon's, you're going to do opposite prayer. So here's prayer, here's opposite, and then you're going to ask them to hold it, and if they feel numbness or tingling, then it's positive. Okay, next we're going to want to go on to our mental health, psychiatric. So we're not psychiatrists, we're not going to do that, so it's basically going to be a quick overview because they are usually going to be managed by psychiatrists, but as a primary care, you're going to have a lot of patients who are coming in with anxiety, depression. These are common stuff that, unfortunately, the whole world is dealing with. So for depression, you want to screen them with a PHQ-2. If they're positive, you want to do a full PHQ-9. And with depression, you always want to ask them about suicide ideations. You want to be very blunt. Just say, do you have any thoughts of harming yourself or others? If they say yes, any plan, any means, etc. If it's a yes, you want to send them directly to the hospital, have some ambulance come take them right away, and etc. If they're not suicidal and you actually, you're just talking to them and everything, you always want to rule out just regular organic cause. It could be just plain depression, but it could be it's caused by hypothyroidism, autoimmune disorders, diabetes, etc. Your first-line medications for depression is going to be your SSRIs. But there are many, many other medications and classes that are available. With your SSRIs, you want to watch out that for your serotonin syndrome, which has symptoms like seizures, tremors, agitation, and if you see that, immediately send them to the ED. You always want to try antidepressants for 4 to 6 weeks at least until the symptoms start improving, and because in general people like to see results from a medication, so they'll take it and then after a week they'll be like, oh, this doesn't work, stop taking it. But with these medications, you have to give them some time to work. And if you are going to discontinue, you want to stop it over 2 weeks. So here's just a list of other ones that you could go over. Your MAOIs, you always want to watch out for tyramine foods. And your lithium is going to be very therapeutic range. You want to check your TREP level, etc. Okay, next we go on to anxiety. So that's going to be screened with a GAD-7. Treatment for that, also first line SSRIs. And you also want to, yoga, exercise, etc. Next we go on to alcohol use disorder. So in order to check for alcohol abuse, besides for the CAGE, which is screening form that you do, you want to do ALT, AST. You could do, the most specific one is the gamma glutamate transferase. This alone, if it's elevated, could clue you into alcohol abuse, as opposed to the ALT and the AST. If it's elevated, it doesn't mean it's alcohol abuse. It could be elevated from other reasons also. Treatment for that, you want to refer them to AAA to help them. You could give them medications like naltrexone, etc. You want to watch out for the withdrawals. That usually could happen 6 to 24 hours after, but it could after the last drink, but it could happen honestly whenever, because every body is different depending on how much they drink, how often, etc. Treatment for that is usually like Ativan, benzodiazepines, etc. You wanna, if someone smokes, you wanna address it at every visit, like, encourage them to quit. And if they're willing to quit, give them medication like acetylene, nicotine, bupropion, etc. Insomnia. So for insomnia, there are medications, but you don't want someone to be on medications for life for insomnia. So you do want them to, get into sleep, regular sleep time, no caffeine before bed, no phone in bed, no watching TV, exercise, yoga, etc. But there are medications like Benadryl could help, but don't give that to the elderly, benzos, supplements like melatonin, etc. Next you have your bipolar. They usually, they go from manic and they flip to depression. So they're completely impulsive, and then the next day whenever they flip, they can't get out of bed. Treatment for that is going to be lithium. This is going to be prescribed by a psychiatrist, but it's a very narrow therapeutic range. Schizophrenia is that they interpret reality just abnormally, like delusions, hallucinations, etc. PTSD could be from any traumatic event. It doesn't have to be from war. It could be from rape. It could be from anything. PTSD. They're going to have like nightmares, flashback, hypervigilance. They think everyone's out to get them. Insomnia. For that, you want to do psychotherapy and medication. The first line would be SSRIs. And the last one is Munchausen syndrome. I didn't pronounce that right. But it's basically when someone fakes an illness because they want attention. But it could also be a mom faking their kid's illness because they want attention. It's very, very, very hard to diagnose. Next we go on to cardiac. There's just a little anatomy, information about cardiac. But what you should know from this is S3 is normal in kids, athletes, pregnant women, but it's abnormal after like 40. So, and for those people who don't fit the categories. And if it is from them, then it indicates congestive heart failure. S4 is always abnormal no matter what, and that indicates a stiff left ventricle. So it's giving resistance. Murmurs, I would for sure know. You have your two types. You have your systolic, you have your diastolic. If you want mnemonic, ask below. I could write that mnemonic. Systolic is between S1 and S2, and diastolic is between S2 and S1. So when it starts again. You should know which murmurs they include. So systolic includes aortic stenosis and mitral regurgitations. Systolic murmurs could radiate. Diastolic murmurs include aortic regurgitation and mitral stenosis. But diastolic murmurs are always abnormal. In terms of murmurs, you don't have to know really the grading, but just know that at grade 4 is when a thrill is present. A thrill is like when you can palpate the murmur. Hypertension. Hypertension is like a whole thing in itself, but basically you should just know like what's considered hypertensive stage 1, what's considered stage 2, and in terms of treatment. So first of all, in order to diagnose it, you need 2 different readings on 2 different occasions. And you could ask them to keep like a blood pressure diary at home, etc. For treatment, you want them to do lifestyle modifications like weight loss, healthy diet, reduce their sodium. Medications are usually initiated first for high-risk patients like someone with more than 10% of ASCVD risk. If you are giving hypertensive, the first line is thiazide, calcium channel blockers, ACE inhibitors, and ARBs. I would know that. Whatever you're doing, whether it's starting a new medication or whether starting a lifestyle modification, you always want to follow up every month until the blood pressure is controlled. When they're on an antihypertensive, you always want to watch out for the opposite to occur, like hypotensive. If someone has hypertensive urgency, which is systolic blood pressure over 180 or diastolic over 120, with no signs of organ damage, you want to get that under control. If someone has hypertensive emergency, which means they do have signs of organ damage, and you want to send them to the ED. Next, we go on to heart failure, which is basically the heart can't pump enough blood to meet the body's needs. You have your different classifications from, you have your 1 to 4 and your A to D. You have your 2 different categories. You have your systolic, your diastolic. The systolic is when the heart can't pump hard enough. Your diastolic is when there's not enough blood filling. So the difference is that when it can't pump hard enough, your ejection fraction is going to be less than 40. If it can't fill diastolic, the ejection fraction could be more than 40. There are two different types. You have your left-sided heart failure, your right-sided heart failure. Your left-sided heart failure, the blood backs up to the lungs, so you're going to have all your pulmonary symptoms, like dyspnea, orthopnea, your crackles. Your right-sided heart failure, it backs up to the blood, so you're going to have like edema, JVD, ascites, etc. It's going to be diagnosed, besides for multiple stuff like EKG, X-ray, but usually an echo is the best way. They're going to put on medication, ACE inhibitors, ARBs, ARNI, beta blockers, but this is going to be managed by a cardiologist. If they're coming in with, they already have been diagnosed and are managed by cardiologists, and they're coming in exacerbation, then you want to send them to the ED. So now we're going to go over acute coronary syndrome, which is basically an umbrella term where blood supplies to the heart is blocked. You're going to have your unstable angina, your NSTEMI, and your STEMI. Your unstable angina is basically not enough blood flow is getting there to beat the blood's heart. But your EKG might not even show anything, and your troponin's not going to be elevated for the most part. Your NSTEMI is when it's partially included, so N, it's not fully, but it's partially occluded. You're going to see on the EKG ST depressants, T-wave inversions, and troponin is going to be elevated. The STEMI, that's going to be much more elevated troponin, and you're going to see ST elevations, hyperacute T-waves, and that's when it's completely occluded. This obviously refer them out to the ED right away. Hyperlipidemia, too much cholesterol, triglycerides. To lower the cholesterol, you're going to give your statins, depending. If they have CVD or 10-year risk of ASCVD, then you want to do, besides for the lifestyle modifications, which is their diet, you want to put them on a high-intensity statin, like atorvastatin, 40 to 80, etc. If it's lower, then you could decide the risk and benefits. If you're going to start with a statin, then you go for atorvastatin 20 and repeat the blood work in 6 weeks until it stabilizes. You always want to emphasize diet change and exercise. Ineffective endocarditis is very specific symptoms, so that's going to be like your key ones. Well, first of all, it's an infection of the endocardium, which is the inner layer of the heart chamber covering the valves. Your key symptoms are going to be splinter hemorrhages, which is under the fingernails, Roth spots, which is white spots in the eyes, Osler nose, which is like painful red raised lesions on the hands and feet, Janeway lesions, which can be fat circular lesions on the palms and soles. And also, they might say it's like a new onset murmur. So if you see any of those symptoms combined or alone, you want to think of ineffective endocarditis. They're going to be on antibiotics to 4 to 6 weeks. The next one is going to be an abdominal aortic aneurysm. This you don't want to miss. A symptom they're going to come in with is sharp back pain and a pulsatile abdominal mass. That's your key ones over there. If it's enlarged, like over 5 centimeters, then it's a large risk of rupture, so then you're going to need a repair. If not, you want to send them to a vascular surgery, and they'll watch it, repeat the ultrasound, etc. Next, we go on to DVT. So DVT is a clot developed in one of the veins. It's usually caused by someone not moving, and coagulation disorders, etc. Symptoms is they're going to have pain in one leg, and this could travel to the lungs, and if it does, it's called a pulmonary embolism. And that is when you're going to start getting the real symptoms. You're going to have shortness of breath, chest pain, etc. If that happens, send them to the ED. They need a D-dimer, they need ultrasound, they need to be sent to the ED. Holman sign is a test that you could test for DVT. Is like you see in the picture, when you're going to passively dorsiflex the ankle, and if it's pain, it's positive. Next, we're going to go on to PAD versus PVD. PAD is peripheral artery disease. Peripheral vascular disease is PVD. The key difference is that PAD is you're going to have your cool, pale legs, hairless, and shining. It's because the arteries bring blood away from the heart, so there's less blood flow to the feet. Peripheral vascular disease is the opposite. It's when the blood can't get back to the heart, so everything's going to pool in extremities. So you're going to see the opposite. You're going to see brown discoloration, the legs are going to be warm, edema, etc. For both those, they're going to be diagnosed through ankle brachial index, and treatment is going to be to stop smoking. So treatment for both is to control the cholesterol, lifestyle modifications, stopping to smoke, exercise, etc. Next we go on to Raymond's phenomenon. That is going to be also very specific symptoms, but what is happening there is an exaggerated vascular response to extreme like cold, etc. The specific symptoms are going to be that their hands are going to go kind of like the fly color. Their fingertips are going to change from white, which is pallor, to blue, which is cyanosis, and red, which is perfusion. So white, blue, red. And they could also have numbness and tingling, but those are going to be your key features. You want to rewarn them, but slowly. So your non-alcoholic fatty liver disease, it's, they're going to have an elevated AST, but they don't drink, they don't use Tylenol. It's usually from their diet. Mitral valve prolapse is a murmur that's described by mid-systolic click. So if you see the word mid-systolic click, you want to think of mitral valve prolapse. It's usually benign, but if it comes with symptoms like palpitations, etc., then it's treated. Next we go on to cardiac arrhythmias. So cardiac arrhythmias is not really going to go into much detail of all these because we're not like cardiologists, but AFib is very common, so that I would know. AFib, is when it's beating out of control, just chaotic. Symptoms are going to come with palpitations, shortness of breath, fatigue. You want to refer them to a cardiologist. Obviously, if they're unstable, they're in rapid AFib, send them to the ED. They're usually going to be put on something like a beta blocker, anticoagulant, etc. If it's a new onset, you also want to order EKG, TSH, electrolytes, renal function, BNP, troponin, etc. For EKG, like I said, we're really not going to go over much, but just to know, I made like a little graph over here. There are 4 walls of the heart: the lateral, inferior, septal, anterior, posterior. This is just plain memorization. Each has a coronary artery that's supplying it, like you see over here. The circumflex supplies the lateral part, the right coronary artery supplies the inferior part, and that all you're going to see that on the leads. So certain leads are going to show you different parts of it. So your V1, V2 is going to show you your septal, which is the left anterior descending, etc. So here's a chart for respiratory. For respiratory, it's a little hard because they all come in with shortness of breath, cough, very non-specific. It's a little hard to know like exactly which one. But I kind of made like a little chart. For lung cancer, if they keep coughing, persistent coughing, you want to always rule out lung cancer or the blood in, especially if they have a history of smoking. It's going to be diagnosed with a low-dose CT, and obviously it's going to be treated not by us. Surgery, radiation, but not in primary care. Carbon monoxide poisoning, that has constitutional symptoms like malaise, headache, mental status change. They're going to have an elevated carboxyhemoglobin level, but you should just know for that their pulse ox is going to be completely off. First of all, you want to give them 100% O2, secure their ABCs, etc. Pulmonary embolism, they're going to have that's going to include sudden onset of shortness of breath, chest pain. They could even have pink frothy sputum, so that's going to be another one. And that's going to be diagnosed with D-dimer, imaging, and they're going to be put on anticoagulations. COVID, every symptom is under COVID, honestly. But your key one over here is going to be a loss of taste and smell. I highly doubt they'll test about it, but just in case you have to know. Symptom management, unless they're high risk, they get monoclonal antibodies, etc. COPD is going to be your daily respiratory symptoms, so it's not going to be sudden like the pulmonary embolism. It's going to be daily respiratory symptoms like coughing, shortness of breath. An approach that we're going to go through soon, the next page. You obviously want to encourage them to quit smoking. That's like the key thing that you want to do. Acute bronchitis, they're going to have a cough, You want to get a good H&P. It's really self-limiting. There's nothing to do. Chronic bronchitis is going to be worsening cough, sputum, shortness of breath. And how it's diagnosed is coughing mucus for 3 months for 2 years. You want to tell them to stop smoking, reduce the environmental, irritants, reduce, etc. RSV is very common, especially with kids, kind of cold-like symptoms, and it's honestly just supportive care, symptomatic. You also have your croup. Croup, the key differentiating thing over there is going to be your barking cough. It's going to sound like a seal-like barking cough. For that, mild can manage at home, supportive. If they need to come to the ED because the stridor, etc., then they're going to be given racemic epi, some steroids to open the airways. It's pretty common in kids under 3. For pneumonia, you have your shortness of breath, cough, greenish sputum. For chest x-ray, for the community-acquired pneumonia, you're going to see consolidations, typical pneumonia, infiltrates you're going to see. The CBC will also have the leukocytes with the shift to the left. You're going to give them antibiotics, amoxicillin, doxycycline, etc. And here's some more. You have your bronchiolitis. That's typically going to be under 2 years old. You have a very fussy infant, low-grade fever, cough, wheezing. If it's not severe, just supportive care. Acute bronchitis can be a cough, sputum production, also self-limiting, nothing to do. So pertussis is something that sticks out because it has your 3 phases. It has the first phase, which is nasal congestion, sneezing, tearing. The second phase, which is intense coughing followed by the whoop. So the key feature here is going to be the whooping cough. So it's going to be like cough, whoop after. And the last phase is going to be a chronic cough for weeks. So this is going to be put on antibiotics. Tuberculosis is the key feature to that is going to be the night sweats, fevers, weight loss. For them, you want to do a chest x-ray. So they're going to be put on a lot of medications, isoniazid, rifampin, ethambutol. What you want to know for this is that when you test them, if it comes out greater than 15 mm of induration, then it's positive. But if they have HIV, then it's greater than 5 is positive. Obstructive sleep apnea. If you suspect this, you want to send them for a sleep study. And then there's different stuff you could do, like weight loss, positive airway pressure, etc. For asthma, they're going to be wheezing, shortness of breath. There's like a stepwise approach that I'll show you in a minute of how to do. So your stepwise approach for COPD, so that's how we know. You have your different groups. So group A means that they have very non-frequent symptoms. So for instance, they only have shortness of breath when they're climbing upstairs, and they have low risk for exacerbation. For them, you want to use a SABA, PRN, short-acting beta-agonist. Your group B is going to be your moderate to severe symptoms, but they also have a low risk for exacerbation. For them, you want to use your LABA, or LAMA. For group C, you're going to have your mild or infrequent symptoms where they're at high risk for exacerbation. You're going to use your regular LAMA and your SABA. For the last group, you're going to use your LAMA and LABA and your SABA. For asthma, you also have a stepwise approach. There's step 1, 2, 3, 4, and 5. Step 1 is when symptoms less than 2. You're just going to have to memorize. There's nothing that sticks out. There's really no way to know this. I would especially know step 3 in all of them because they usually don't ask for like step 1 or step 5. Okay, now we go on to the endocrine system. So we're going to skip over the pathophysiology part for the purpose of this video, how it works and the hormones, but we're going to go on to hypothyroidism. So hypothyroidism is really common. And so number 1, what you should know is hypothyroidism, how you're going to find it. It's going to be TSH. So your first thing you're going to order is a TSH, and if that's abnormal, then you could order T3 and T4. So TSH is an inverse relationship with what you would think it is. So if it's hypothyroidism, then TSH is high and T3 and T4 are low. And the reason for that is because just think about it like this. If TSH is the one that tells your brain that you have a low amount of thyroid. So you're going to have a low amount of actual hormones like T3 and T4, but you're going to have an increase in TSH because of the low amount of T3 and T4. Anyways, causes could be Hashimoto Thyroiditis is one of the most common. It's an autoimmune disorder, and it gradually destroys the thyroid. So your symptoms of hypothyroidism are going to be like slowing down, and hyperthyroidism are going to be like the opposite, like amping everything up. So slowing everything down, just think of like weight gain, constipation, fatigue, just everything like down. And very late signs could be like facial puffiness, cardiac signs, coarse hair, etc. Your treatment's going to be Synthroid. They should take it the first thing in the morning, empty stomach, etc. A complication of untreated hypothyroidism is myxedema coma. And that's going to be, just think of, your everything that goes down for hypothyroidism, like weight gain, constipation, everything slowing down. Just think of even worse. So you're going to be confusion, lethargy, and really, really, really low core body temperature, etc. And this is pretty fatal, so you want to send them to the ED. Now, the opposite of hypothyroidism is pretty self-explanatory. You're going to have a decrease in TSH and high of the actual hormones like T3 and T4. Causes: Graves' disease is the most common cause. It's also an autoimmune disorder that overproduces the hormones T3 and T4. Symptoms, like I said, are going to be the opposite of everything slowing down. Everything is like amped up, like anxiety, palpitations, weight loss, increased appetite, etc. And treatment, so there's PTU and there's Tapazole. So PTU is, you need like a lot of lab work for that, and it's given multiple times a day, so it's generally not given, but the only times that you really give PTU is in the first trimester of pregnancy. After the first trimester, you switch to Tapazole. If it's Graves' disease, the treatment radioactive iodine. Complications of untreated hyperthyroidism is thyroid storm. And this is life-threatening also. You want to send them to the ED. Thyroid cancer, we're going to skip that for now. Hyperprolactinemia, you're going to have like menstrual dysfunction, symptoms, infertility, etc. Diabetes. Diabetes is really common also. Type 1 is not as common as type 2. The difference between them is that type 1 is when the body makes very little or no insulin. Type 2 is that they do have beta cells, but their body prevents the insulin from working properly. So the goal in type 2 is to stop the destruction of the beta cells so they can secrete insulin. And in type 1, they have basically no insulin, so you have to give them insulin. Type 2, your risk factors for developing that, obesity, I'm sure you'll know this, unhealthy eating, etc. Symptoms are going to be like your P's, polydipsia, polyuria, polyphagia. Another sign is acanthus nigeria, which is like the brown discoloration. And so I would just memorize what's considered pre-diabetic and diabetic. You have to just memorize that. And the treatment, like we all know, first we go into lifestyle modifications, then the first line is always metformin, unless it's contraindicated, and then your other ones you could go on to your TZD, GLP-1, etc. And if it's still not working, you could add a sulfonamides, basal insulin, and that's not working, insulin. The complications of diabetes, we all know it could affect the eyes, the kidneys, the heart, etc. And you want to prevent these complications. So do yearly eye exams, do foot exams, especially because they have decreased sensation, so they might not be able to pick up on something that's down there, and then it could, be in a worse state of when you could have treated it before. Next, we're going to hypoglycemia. So that's a decrease in the blood sugar. That could be even from too much diabetes medications. Treatment for this is going to be, if a patient's awake, you give them 15 grams of glucose, and then like orange juice, let's just say, and then you could retest it 15 minutes later. If they're not awake or unconscious or stuff like that, or just can't tolerate oral, then the glucagon you give them. Next, we're going to two conditions that cause high blood sugar in the morning, but they're different, and then they're treated differently. So the dawn phenomenon and the Somoji effect. And a hint I like to remember this is dawn is down, Somoji is so much. So down, what I mean by down is they didn't have enough insulin, so then in the middle of the night, the blood sugar kind of just spikes, and then you wake up in the morning and they have hyperglycemia even though they didn't eat anything before. So the treatment for this is to increase insulin because you have down, so dawn down, too little insulin you gave them in the morning, so they spike and you got to give them more. The Somoji effect is the opposite. Somoji, too much insulin, and then the body senses that the blood sugar falls, So it's going to counter-regulate and produce hormones that are going to bring up the blood sugar. So when you take it in the morning, they're going to be hyperglycemic, but really it's because of the hormones. So for the dawn phenomenon, because it's down too little, you're going to give them insulin. For Simoji effect, you give them too much, you want to decrease that insulin. Another endocrine disease that is too much and too little is Addison and Cushing's. Addison means that you give them too little cortisol. Cushing's, give them too much cortisol. And I like to remember that because Cushing starts with a C, so cortisol, you give them too much. Addison, give them too little. And the symptoms, these are going to be like specific symptoms. Hyperpigmentation, they look like tan, bronze, however the book terms it, and that's going to be your Addison. And their labs are everything's going to be low, except for they have a high potassium. And with the Cushing's, all the labs are going to be up, except potassium is going to be low. And their symptoms that specific are moon face, purple striae, truncal obesity, etc. And last but not least is SLE, systemic lupus, is an autoimmune disorder that could basically affect almost any organ. And it's really hard to diagnose because it can mimic a lot of other diseases. For instance, you could have vague symptoms like fatigue, fever, or weight loss, or you could have other symptoms like arthritis, skin lesions. So it's really hard to diagnose, just because it's so unspecific symptoms. It's commonly a flare-up with photosensitivity, and it's going to be diagnosed with positive ANA tests with symptoms plus labs. This is not going to be handled by primary care. This is referral to rheumatologists. So we go into hematology. Hematology, we start off with some numbers you should know, like the platelet counts, what's normal, abnormal. And then we go into anemias. So the tests like to ask, what's the first test you do to test for anemia? Number one is a CBC. You always start with your CBC. After that, you could do your hemoglobin electrophoresis, etc. But you always start out with your CBC. Now we have different terms you should know. So your MCV. MCV is mean corpuscle value. And how I like to remember this is V. I think of an SUV. So SUVs come in all different sizes, and people like big ones, like Tahoes, etc. So what V is going to stand for, like CV is going to stand for, is it's going to tell you the size. We have your macrocytic, your microcytic, and your normocytic. So normal is normal, micro is below, and macro is above. And all you have to do is remember the regular range, like 80 to 100, and then anything above, macro, is above 100. Anything below is below 80, and the normal is in between. So just think of your V, like your CV, so MCV. Just think of your SUV. Comes in all different sizes. Next we go on to MCHG, so mean corpuscle hemoglobin concentration. So that and the mean corpuscle hemoglobin both tell you the color. So I just like to think of anything with the H in it, like hemoglobin, is U, like HUE. So that's color. That's going to tell you the color. So hemoglobin U will tell you color. Your TIBC is your total iron binding capacity. And this basically tells you how much transferrin is just sitting there not attached. So what transferrin is, it attaches to iron and it transports it throughout the body. So if transferrin is just sitting there, that means that iron's not attaching to it. So that is an indirect measure for you. And how I like to remember this is T, IBC, so T is total iron binding capacity, and T is for transferrin. Next we go on to serum ferritin. This is the most sensitive for iron deficiency anemia specifically. And it tells you how much iron is stored. And then it goes into iron. Reticulocytes are immature red blood cells in the bone marrow, and how I like to remember that is reticulocytes, like they're ridiculous, they're immature. Next we go on to our red cell distribution width, so RDW, and that's like the width, the distribution, so then you remember all different variations. Poikilocytosis is basically measure the variable shape of the red blood cells. You have different types of anemias. You have your macrocytic, your microcytic, and your normocytic, like we said before. So your microcytic, one of the most common ones are your iron deficiency anemia. And I would remember the symptoms for that. Some symptoms they could be having is nail pitting, pica, which is like they eat stuff that are not food, spoon-shaped nails, regular anemia symptoms like pale, fatigue, and chelosis, which is like the chappedness in the corners of the mouth, and a shiny red tongue. Glossitis. For that, treatment is going to be iron. The most common cause is blood loss, so think of your menses, diet, etc. And you always want to rule out malignancy, etc. The next one is thalassemia. That's usually genetic, like Mediterraneans. It's just when the body makes a defective hemoglobin. It's diagnosed with your hemoglobin electrophoresis. If it's minor, there's really no treatment. If it's major, then they need like transfusions, and you want to be concerned for iron overload. Normocytic, so the MCV. So like I said, SUV, the size of it is normal. You have anemia of chronic kidney disease, which is basically the body doesn't make enough secondary to chronic kidney disease. You have anemia of chronic disease, so like autoimmune disorders. Obviously with that, you want to treat the underlying disorder, and you have your sickle cell anemia. That is genetic. It's generally autosomal recessive. The red blood cells are sickle shaped, so they could get stuck. It's also diagnosed with hemoglobin electrophoresis, and this is more common in African Americans, and it's managed by a hematologist. And last but not least, you have your macrocytic, so the MCV is high. You have your B12 anemia. What they like to ask about this for the B12 is that it has neurosymptoms. So it has your numbness, your tingling, dizziness. So if you have like an anemia question that has some neurosymptoms, just think of B12. Also, it could have the glossitis, the beefy red tongue. It's usually caused with diets like vegan or even gastric bypass. Your next macrocytic is folic acid, folic deficiency anemia, and that's from inadequate consumption, alcoholism, pregnancy, and you want to treat it with giving them folic acid. The next one is pernicious anemia. That's an autoimmune causing termination of the intrinsic factor. So this leads to B12 deficiency anemia. So whenever you think of pernicious anemia, just think of B12 deficiency anemia. So you want to treat them with B12 injections once per week for 4 weeks, and then do monthly. Then you have your aplastic anemia, which is destruction of the stem cells, so like in the bone marrow. Symptoms, because it's not specific to red blood cells, so it includes red blood cells, white blood cells, platelets. So you're going to have your pantocytopenia. So you're going to have, you could have bruises, infection, etc. And this you want to refer to your hematologist as soon as possible. Next you go on to your HIV. So you want to screen for that. You know, it's mostly spread by intercourse, needles, etc. There are 3 stages. First, they get the flu-like symptoms, and they could go asymptomatic, which could be for years, and then they'll have the return of symptoms, which you want to treat them. You want to know how it's diagnosed, and you want to watch out for the CD4 count. Because if it's less than 200, then you could call them AIDS, and then they're at risk for infection, immunosuppressed, so no live vaccines, etc. Okay, next we go on to our GI notes. So here, like on top, is just basically, you know, it's good to know your anatomy, because if someone comes in with right upper quadrant pain, then you want to think of, you know, the gallbladder, not like the ovaries, right? So you basically just have to know what's in every quadrant to know, you know, more specific diagnosis. Here's acute abdomen. So this is stuff you want to treat, and you always want to rule these out and send it to the ED if they have any of these. So these are specific symptoms. So your peritonitis, you're going to have your Blumberg sign. We're going to go through the signs in another page, but I also have a video on that sign. You have your bleeding, so you're like bleeding internally. You'll have your Gray Turner sign, your Cullen sign. You have your acute cholestasis. You're going to have your right upper quadrant pain, or your Murphy sign. You have your acute pancreatitis, which is left upper quadrant, or epigastric pain. You're going to have your Cullen sign, your Gray Turner sign. You have acute appendicitis, which is usually your right lower quadrant pain, and your McBurney's point, psoas, etc. And last but not least, you have your acute diverticulitis, which is your left lower quadrant pain. So this is assessment signs that are specific to GI, like Cullen sign, McBurney sign, Murphy sign. These are all stuff you have to know, and I've seen this on the test so many times, and I know a lot of people who had this on the test. there's GI signs, there's signs in, for DVTs, etc. So what I would do is I would either watch my video where I have this in detail. I'll put the link below or above and watch that. It's like 10 minutes or less than 10 minutes, and it will explain you everything. So I'm going to skip it for now. Okay, now we're going to go into GERD. So GERD, we probably all know. The treatment for that, for mild and intermittent, you want to give them a low dose H2 receptor like famotidine or antacids. If the symptoms still persist, you could increase it 2 times a day. If it still persists, you could add on a PPI, and etc. Some complications you want to watch out for is Barrett esophagus and esophageal cancer. Next, we go on to peptic ulcer disease. Its most common cause is H. pylori, but it could also be from NSAIDs, stress could even cause it, smoking, etc. They're going to come with epigastric pain or even food that provokes with epigastric pain. You have your gastric ulcer and your duodenal ulcer. If it's in the stomach, which is the gastric ulcer, then when they eat, they're going to have a lot of pain because it's in the stomach. If it's in the duodenal, which is the small intestines, then it takes, a little bit of time to get to the small intestines. It starts in this. Then 1 to 3 hours later, then they're going to start, after they eat, then they're going to start getting pain. It's usually diagnosed through endoscopy, and you want to test them for H. pylori. And first of all, you want to treat them to remove the cause, like the stress, the NSAIDs, etc. And you can treat them with PPIs, H2 blockers. Compare and contrast IBD and IBS. So I like to think of IBD as D for disaster. So IBD is more severe than IBS. And the reason for that is IBD is when it involves the bowel is inflamed, so it causes a lot of damage, and IBS it's not. And you can just look at the name. One's inflammatory bowel disease, so there's inflammation going on, and one's irritation. So the thing about this is that with IBD, with inflammation, it could cause a lot of damage, and they're at risk for increased risk for colon cancer. The symptoms could be quite the same, but with IBS, a lot of times they'll have mucus in the stool, gassy, blowy, abdominal distension, etc. Abdominal pain. And in terms of the treatment, so with IBS, you want to do diet, stress reduction, you always want to rule out other causes, etc. But with IBD, it's usually with medication. Now, under IBD, so you have ulcerative colitis and Crohn's disease. They're both chronic inflammation from the GI tract. Because remember, IBD is inflammation, so they're both inflammatory. The difference is that ulcerative colitis is in the large intestines, and Crohn's disease could be anywhere in the GI tract, but usually in the small intestines. But the ulcerative colitis is only in the large intestines. And the inflammation in ulcerative colitis is continuous, in Crohn's disease it is not continuous. And here are some risk factors. Symptoms are a little bit different, but a lot of them are the same. So they both have diarrhea, they both have abdominal pain, both have extraintestinal manifestations, both have blood in the stool. But if you're talking about mouth sores, anal fistulas, malnutrition, it's usually Crohn's disease, and talking about blood in the stool, it's usually ulcerative colitis. But it's a little hard to differentiate. So next we go on to C. diff. C. diff is very common with antibiotic use, especially certain antibiotics. And what they're going to have is severe watery, it's going to have a smell, and they could also have fever, lower abdominal pain, etc. But mainly the smelly diarrhea. The treatment is going to be to obviously stop the antibiotics use, contact precaution because it's spread that way, hand hygiene, and with them you want to do soap and water, not alcohol. And then you're going to give them treatment is Vanco, etc. So next we go into colon cancer. One of the symptoms are a change in bowel habits. That's a big one. Ribbon shape, thin like pencil stool. It could also be from constipation, but it could also be a sign of colorectal cancer. But usually a change in bowel habits is a big one, weight loss, etc. It's diagnosed through colonoscopy, and you want to do a colonoscopy for prevention, like part of the screenings. Next we go on to hepatitis. Hepatitis is itis, so it's inflammation of the liver, and it's usually due to a virus. Symptoms are fever, malaise, nausea, jaundice is a big one. It has to do with the liver, hepatomegaly, and increased ALT and AST. ALT and AST are always the liver. So, like we mentioned before, GGT is elevated and it indicates alcoholism. ALP, elevated, but could also be elevated due to bone growth or disorders. And IgM is when it's active, IgG is when recovery. So I like to think about it as G as gone, and M is like immediate now. So now we just have a quick chart of hepatitis. So you see your A, B, C, D, E, and what you should know is that which ones are chronic, your B, C, D, not your A and E. A and E are both spread the same way. They're fecal oral. The most severe one is usually B because it's linked to liver cancer, and A is usually mild. You can just read through this chart. The treatment's the same for all of them. Supportive. If they're not vaccinated, get the vaccine. They're reportable to the health department. For chronic ones like B and C, like I said, those are the most severe. You want to refer them to a gastroenterologist. So next we go on to our GU system. So we have our kidney, we have the pathophysiology on that, and just some stuff by the red blood cells. You can read up on that. But now we talk about acute renal failure, AKI, acute kidney injury. So symptoms that usually point to the kidney are decreased urine output, fluid retention, edema, etc. So acute kidney injury could be caused from pre-renal, which is stuff like before the kidney, so hypovolemia, post-renal, stuff after the kidney, so think of your bladder, so like a bladder obstruction, or intrinsic, so the actual kidney. So acute kidney injury, you fix the cause, whatever causing it, and then it goes away. Chronic kidney injury is kidney damage for more than 3 months. Usually the cause is hypertension or diabetes, which is why you always want to manage those so it doesn't end up in kidney failure. There are 3 stages, and the stages are based on the GFR. Number 1, kidney damage with normal GFR, mild kidney function loss, moderate, severe. Sorry, not 3, 5 stages, and end-stage renal failure. So I would know that the symptoms begin at stage 3, so that's why you want to refer them out to nephrologist. Next we go on to UTI. UTI is very common. It presents the same way, urinary frequency, burning, pain, etc. But with elderly, they could have confusion is a big one, and you want to think UTI. If they have flank pain, it could have spread to the kidney, which is called pyelonephritis, which is when it spreads upwards to the kidney. And that usually comes with fever, chills, etc. It's usually diagnosed through a UA by the leukocytes and the nitrates. If those are positive, then the person has a UTI. You could send it for a culture to see which exact bacteria they have it. Treatment for that, I would know this because this is quite common, is if someone is non-complicated, so you could do macrobid, Bactrim, etc. If someone's complicated, which could be someone who recurrent UTIs, a male, someone pregnant, then you want to give them ciprofloxacin, and if they're pregnant, you want to give them penicillin. Next we'll go on to kidney stone. They are usually coming in with the flank pain, hematuria, nausea, vomiting, etc. You want to do labs of them and get a CAT scan of their abdomen and pelvis. Treatment is going to be, besides for pain medication, because it is quite painful, hydration until the stone passes. If the stone is large, then and they can't pass it on themselves, then you want them to give them like tamsulosin or something to help them. Next we go on to rhabdomyolysis, and rhabdomyolysis is damaged muscle. So when the damaged muscle breaks down, it releases content into the blood. And this is pretty harmful for the kidneys, so it causes them to go into acute renal injury. This could be from stuff like a statin, too much exercise, etc. You're gonna diagnose it because they're gonna have CK levels like through the roof, like 5 times the normal amount. And the treatment is going to be fluids in the ED. So you're going to refer them to ED and let them handle that. Now we go on to STIs. So So you have your gonorrhea. Gonorrhea and chlamydia are co-treated. So if someone has gonorrhea, you're going to treat them for chlamydia and vice versa. So the treatment for gonorrhea is going to be ceftriaxone, which is Rocephin, 1-time dose IM. The treatment for chlamydia is doxycycline 100. But so like I just said before, you're treating one, you're treating both of them together. Then we go on to syphilis. What I would know about syphilis is the symptoms. It comes in 3 stages, so it has a transfer, the diffuse rash, and then it affects the whole body. I would also know what medication to give them, which is penicillin G. IM. Next, we're going to trick. Trick has specifics. It's usually green, grayish discharge that you want to know about, and the treatment is metronidazole. The next one is HIV. You have symptoms like fever, lymphadenopathy, sore throat, rash, etc. And for them, the treatment really depends on their stage, if they have opportunistic infections, etc. So next we go on to HPV. HPV, what you should know about that is it's usually genital warts. And that's how it can be described, some sort of warts in anal, genital area. In terms of what you should know about this, I would know is that the strain 16 and 18 are linked to cervical cancer, so that's important to know. When you go on to your hepatitis B, we already discussed the symptoms. You're gonna have your nausea, abdominal pain, jaundice is always the liver key, etc. And we already said what we did before, the supportive care, referral, etc. Other information is important to know. Anytime you treat trick, you want to treat gonorrhea. When an STD is found, you always want another STD test if they would like to. And for most of the STDs, you want to bring the partner in also to treat. And last but not least from this page, we're going to go into pelvic inflammatory disease. This is actually a complication of gonorrhea and chlamydia. Symptoms are going to be specific because they're going to tell you, besides for lower abdominal pain, pelvic pain, etc., they're also going to tell you cervical motion or adnexal tenderness. So if you ever hear those words, or cervical friability, then you always want to think of pelvic inflammatory disease. Treatment, like we said, because it's the complication of gonorrhea and chlamydia, you want to treat the gonorrhea and chlamydia. So you want to give the ceftriaxone, the doxycycline, etc. So thank you for watching. This is part 1 out of 2 of the Family Nurse Practitioner Board Review Examination. So we're going to have one more video, probably be around an hour long, and then that'll be the whole board review. So like I said, this doesn't go into every single detail, but this is a good comprehensive review. So if you have any questions or any comments or suggestions, please put it in the comment section below. And if you like all this in note form, so you could, highlight or whatever you want it, then check out the other link below. And thank you for watching. Bye.